introducing everyone, I'm going to let the first question panelists introduce themselves a little bit and where they come from. So we're going to start with Sarah, who's coming from WHO and the Health Emergencies Program. And Sarah, kick us off and talk to us about your own experience through the COVID pandemic. What was it like to try to build trust across so many countries as part of a global institution? What are some of the lessons that came out of that for you?
Thanks very much, and really nice to be here today in front of everybody. I think we learned many things, and probably the first one is that trust is very poorly defined in the context of epidemics and pandemics. I think when we talk about trust and pandemics, people immediately think trust between people and the government and trust in the vaccine, and it's a very limited understanding of trust. So the first real learning that we garnered from the pandemic is that trust has many different dimensions. In the context of epidemics and pandemics, you could talk about trust in data. We talked a lot about that in one of the plenaries. Who's got the data? What are they using it for? What is the privacy around that, for example? You could talk about trust in the health system. Do people trust healthcare workers? What were their previous experiences in the healthcare system that now mean that they don't trust it? Are they having access to countermeasures? Are they being served by the health system? That will all impact trust in the context of epidemics and pandemics. If you talk about community trust and interpersonal trust, that's got many historical connotations and contexts as well that need to be taken into consideration. And so it's very difficult at the global level to do something that impacts and affects trust at a local level, because it's very clear that trust is very context specific and you can't apply a one-size-fits-all approach to it. I think one of the commonalities though is that trust is really intrinsically relational, and you can't talk about trust as a commodity but more without talking about things like trustworthiness. So what are the characteristics of trustworthiness? Two things that came across very strongly in the work that we were doing throughout the pandemic at WHO is the issue around transparency and the impact that that has on trust. And then the second one is the issue or the disconnect in some cases between science and policy. So transparency is obviously linked to that, because transparency is really like, what do we know? What do we not know? And what are we doing? So how is that knowledge then translated into that action? And there was a breakdown there often in many situations. And this was linked then again to the science and the evidence, and how that was then translated into policy recommendations, and how these policy recommendations might have been very removed from local contexts, local cultures, local needs. And so what we've been trying to do is to try and build some of the kind of research and understanding around trust in the context of epidemics and pandemics. How do you then move into that process of localization? So how do you take that knowledge and localize it so that you can identify interventions that build trust during the inter-pandemic periods and sustain trust when there is a crisis? I'll stop there, but happy to share more later on.
Excellent. Thanks, Sarah. There's so much more to dive in. I'm going to pick up on that point on localization. Mia is joining us from South Africa, and I'm going to ask you to start by just introducing your journalism center, the Bhekisisa Health Journalism Center. What does Bhekisisa mean?
That's a great question. So we are very local, only in South Africa, and Bhekisisa is a Zulu word. It's our largest language in South Africa. And it means to look closely at something or to scrutinize something. So if a Zulu patient goes to a doctor in South Africa and they want the doctor to check them out really well, they'll say Bhekisisa me. And so that's why we're the Bhekisisa Center for Health Journalism. We look at issues closely. And during COVID, we started off 10 years ago as the health desk of a newspaper in South Africa. And we then wanted to access a larger audience. And unknowingly, 6 months before COVID, we made that move, but didn't know a pandemic was going to happen. And it was obviously, in a weird way, a very good thing for us to happen, because all of a sudden, our small organization was the almost mainstream form of information. We published all our content on the mainstream publications in South Africa. And we were 2 reporters and myself, I'm the editor, and the 2 print reporters, myself, and 2 multimedia reporters. And we had to fill up a week of coverage for 4 mainstream publications, and we had a daily slot on a television station. So each day from Monday to Friday, someone had to either talk about a story or break down a COVID issue. And it was a period of a lot of growth. Shall I end with that?
And before I move on, can you just share a few of your top takeaway lessons from that experience?
So I think the most important lesson I learned from COVID as a journalist is that accurate information is pretty useless if people can't understand it. And that's not just a cliche, it's a real skill to make it understandable. When we produce stories and when we edit stories, I would say at least 2/3 of the time is spent on de-jargoning the story. Now, our journalists were pretty well prepared for COVID because we do evidence-based journalism, and by that I don't mean stuff that's just true. I mean our journalists have an understanding of research methodology, and they quote peer-reviewed studies. So when COVID happened, we knew what the difference between a peer-reviewed study and a preprint was, and that vaccines don't all work in the same way, that sort of thing. So that prepared us well. But that didn't mean that we didn't have to spend very long hours on de-jargoning stuff. So governments who issued press releases and talk of adverse events, no one knows what that is. We did it the other way around. We would go and explain what it is, or we would use a different word. We wouldn't say it's a rare side effect. We would explain how many people in 1,000 or in 10,000 need to have that for it to be called a rare side effect. The other thing that I learned was that consistency is the currency of trust. If you are not consistent with what you do and you don't get it right every single time and make it easy every single time, you don't gain trust. And that's a mistake our health department in South Africa made. They were sometimes very good with communication, but very often they were just long periods of nothing, and that does not build trust. But for us to build that trust and to try and get things right and to spend that time on making it easy to understand, we had to buy time somehow, because those stories take longer to do than a story where you just copy and paste the first paragraph of a press release. So we had to learn to do things differently to buy that time. So if we wanted to do an in-depth print story, we learned to make short videos because that's quick to make, and then we could use that time to do another print story that will take longer. We had to learn to adjust our definition of a story, because during COVID, people didn't necessarily go to a website all the time and access information. They got stuff from social media. So we had to learn to do stories like Twitter threads that we wouldn't publish on our website, or to create infographics and learn how to do that. And just do it on social media, because that's where people accessed it. And during a pandemic, you want to repeat information, but you can't repeat it in the same way. People will get just like bored of it. So you need to repeat it in different formats. So we learned to do a print story, do a small podcast of exactly the same thing. We would record the interview for the print story in a good way, and then do a print story, do a podcast, and then do a short video. And it would all just look a bit different, but it's actually the same information. Last thing is, because everything happens faster during a pandemic, you need to get everything done faster. And you can't do it alone. You have to form partnerships. You can't get to the faster bit if you don't form partnerships. And that is something that we really learned, but that is continuing really because of COVID. So we, a national television station, didn't have science correspondents. So it was their idea to partner with us and have a daily slot. But we didn't have data journalism skills, but we had very good contacts in the health department. They would give us information that they wouldn't give other media organizations. So we partnered with a data journalism organization in South Africa, and we created a daily dashboard. And it's not that the government's dashboard was, wrong, but people couldn't understand it. It wasn't accessible. So even in ministerial advisory committees, it was our dashboard that was quoted, not the health departments. And we could never have produced it without the data journalism organization. They would never have had the information without us. And it becomes so much more powerful when you partner. And another interesting partnership that happened was our audience is a very niche decision-making audience. So we want to reach academics and scientists and politicians. So for us to go and partner with a community media organization makes no sense because it's a different audience. But during lockdown, we couldn't get access to townships in South Africa. And the issues in townships played out in a very different way from the rest of South Africa. People couldn't get access to their social grants, so they didn't have food. So we partnered with a grassroots organization who had untrained people who just had video cameras and went to do interviews with those people. And it became a very strong partnership. We applied for a grant together, a National Research Foundation grant that you would never think a community organization would do. And we could never, on our side, have done our work without them. So COVID made for interesting partnerships. And today, as a result of our TV experience, we really had none before COVID. We have a national television program, a 30-minute program once a month on a national station. Wouldn't have happened without COVID.
Thanks, Mia. We're definitely going to come back to this theme of partnerships again. I'm going to keep going along the line so everyone gets a chance to know who's on our panel today. Eloise, Todd, you're the director of the Pandemic Action Network. I'm sure you've done a lot of collaboration and partnership building on this. Tell us a little bit more about what PAN does and your experience with trust during the pandemic.
Thanks. So the reason that the Pandemic Action Network was formed, a few like-minded people kind of found each other in March 2020, mostly with a civil society background, worried about the fact that governments were taking these very different life and death decisions in very different directions, and where was civil society's voice? There's a huge global health sector, but actually not that much focused on pandemic threats and all the related issues. And so there's this lack of confidence in the civil society movement because, of course, COVID was novel and we didn't know what was coming. But it was like we've got to find a way to channel expertise to give civil society a voice. And so that was the sort of thesis behind Pandemic Action Network, to provide a platform for global civil society, but also, crucially, other organizations too. So we launched with 25 partners on the 22nd of April 2020. We've now got 350 plus partners. Of course, they're not all active all the time. Some are kind of sleepers that come on board for campaigns. But we do get, 70 people, 70 orgs each week on our advocacy calls. And it's not only civil society, there's private sector, there's foundations, there's international organizations, there's media groups as well. And one of the things about trust when we first started was, I remember my fellow co-founder, David Kine, who's in the comms business, and he said, until we have pandemic countermeasures, communications is our tool. And so that's how we get people, that's how we spread information about what people should be doing and not doing, how we build confidence in what should happen. From the outset, we actually set up a monthly behavior change working group, which is still going on today. And through that group, we tackled issues in the early days on masking, for example, and we put together a masking campaign that actually we ended up nudging WHO a bit. They were a bit hesitant at first on the masking issue, and we ended up kind of pushing that to a point where they also came out a bit more strongly on the data that was out there. But what was important about that behaviour change working group, and it remains important today, is it provided a place for experts, companies, governments, anyone doing research in communications, and particularly vaccine hesitancy, to come together and share their findings. And that concept of collaboration and that concept of we can't do this alone, we have to crowd in expertise, not only from across sectors but across different countries, is absolutely key, especially during a crisis. And so of all the problems of remote working and lockdown, that sort of Zoom experience was the great leveller, time zones permitting. And we were able to have these kind of monthly working groups where in an hour each month we'd have like 6 10-minute talks, almost like mini TED Talks, on people really crunching their data and sharing. And that generosity of data was actually hugely important as well. So in terms of some of the things that Pandemic Action Network did, particularly in 2021, at the beginning of the vaccine rollout and into 2022, we also partnered with different organisations, local community groups in South Africa and university research groups, to look at food vouchers being used in combination with trying to get people involved in and more trusting in the kind of vaccine process. So not just, this is what you need, take it. Actually, if they're hungry, that's what they need too. So trying to understand that you can't just go there with the thing you want to give, but looking at the broader holistic piece. And then another particular project we got engaged in on the trust side was one in the US, trying to get people of colour, different groups, to be vaccinated, and working a very different approach there with celebrities and influencers, and a whole series of webinars on that, which proved really important. And that was also the sort of use of the celebrities was also to engage and empower community leaders so that they had the tools to be able to share the messages with their groups. So it's there are some fundamentals that don't ever change in this trust business, which is it's always about the messenger. Ideally, it's peer-to-peer. We see that in our own social networks. If your friends and family are doing something, you're more likely to do it. But of course, you've got your community leaders, and you really need to kind of have those established networks. And we'll probably get to this later in the conversation, but I think we're still going with our behaviour change working group, and we're still trying to make sure the tide doesn't go out on all of those findings and all of that good work that's been going on. Because we absolutely, I was thinking this morning as we were listening to the brilliant presentations in the room, the always-on concept needs to apply to hesitancy and trust, and all of those things. So how can we keep those connections? How can we keep exploring the vast amounts of research and data that have been looked at over the years, and make sure we're gleaning the lessons from them and acting on them?
Thank you so much. Yes, we will definitely get back to some of the actions to stay always on. Now I am going to turn to Dr. Tanvi Rai from Oxford University. And we've heard a lot about localization, the messenger. Tell us more about your research, what you did through the pandemic, what you've learned about the roots of mistrust that come in communities.
Thank you. I'm a health researcher, a health inequalities researcher in Oxford University, and as some of you might know, that once the pandemic started, a lot of funding went to COVID research. So everybody in health research was doing some form of COVID research. So I was also involved in a couple of projects which were on experiences of the pandemic, both of the illness itself, but just more generally as well. And one of the projects, the particular brief that we had was to kind of really go and talk to people who were most disproportionately affected. So these would be the kind of essential workers, people like doctors and nurses and postal workers and transport workers and like the highly exposed people, as well as racially minoritized people who, and there is an overlap in that and the previous category. What was really clear in the pandemic, I mean, initially, you might remember in 2020, everybody was saying, oh, this is affecting all of us the same, we're all in the same boat. But it became very clear quite early on, especially in high-income countries like the UK, that we were not all in the same boat. There were some people who could pivot quite quickly and start working from home and could adjust their lives. And, the conversations they were having with their friends and family were about how, their kids were driving them up the wall and that kind of thing. Whereas the conversations that other people were having were more about so-and-so has died, and now my uncle has died, and now my friend has died. So it was like very stark. We were definitely not all in the same boat. So what the pandemic did was to just expose exactly the same kind of cracks and fissures that exist in UK society. They followed exactly the same patterns. You could take any health condition. So there was nothing that exceptional about COVID in the sense that it just exposed and exacerbated the same problems that we have of health inequalities, and not just health inequalities, but also to do with, economic security, housing, employment, all of those things. So all it did was kind of lay it wide open. The other thing that happened was that because a lot of people were at home and seeing the news a lot, it became amplified. So people were like, oh my goodness, what is this? How do we live in such a broken society? And so this was kind of news to some people and not news to others. So it kind of exposed this inequality. The other thing it did was, unfortunately, in the way that it was portrayed in the media, where certain groups, certain racialized groups, were identified as being at greater risk, having much worse outcomes. And this was stark, and it didn't seem to matter whether you were a kind of hospital consultant or whether you were a porter. It was it seemed to, be along racial lines that people were having much, much worse outcomes. Unfortunately, what it did by the kind of rhetoric that the media was using was kind of pathologizing people. So people were looking for answers, and they were like, is it genetics? Is it something that they do? So it was either some kind of cultural or social pathology or biological pathology, completely, and using, racialized terms as if they held some sort of scientific basis, which it doesn't. We know that from the Human Genome Project that there is no such thing as race on a biological level. So it was kind of, these are very problematic categories, but they were being used repeatedly in ways that kind of had the negative effect of making people who already feel, in this broken society, already feel quite, in a corner and not listened to, again, further blamed for the way that the pandemic was spreading. So we, in this research, we interviewed quite a lot of, the majority of people who were in these kind of highly exposed settings. And got a real sense of the mismatch between the very didactic kind of rules about this is what you should do now, stay at home, don't go anywhere, don't do this, and then the reality of people's lives where people are working on 0-hour contracts. If they don't go to work, they don't get paid. If they don't get paid, they can't eat, they can't feed their families. And then kind of, very specific examples of kind of people having to, work early shifts and standing at the bus stop with say, a billboard. I don't know if you remember, but there were, certainly the people in the UK might remember, there were pictures of people in hospital severely ill, and it said, look into his eyes and say that you're going to go to work today and spread COVID. And these are really powerful. And so if you think of, care staff or a hospital porter who has to go to work, who's called an essential worker, and then they're faced with these kinds of images and no kind of social security or fallback support, it was a very different experience of the pandemic. So I mean, all of these things got very clear very quickly from talking to people. but we can talk about more of that.
I'm going to continue
Go on.
because, this is so striking. So what do we do better?
I think, a lot have been, I'm sure we will talk about vaccines because there's a lot of interest in vaccines. But I get confronted quite a lot by questions about vaccine hesitancy and how particularly racialized groups are hesitant. And is it because, they don't understand science, or is it because, they're just generally, not trusting of policies that make them do things? And I think that's a very ahistorical way of looking at things, decontextualized way of looking at things. There's a lot of bad stuff that has happened in the past and continues to happen. And I think that the kind of very didactic, you must do this because it's good for you, it fails to recognize that the roots of mistrust come from the very real violations and basically medical poor behavior that has happened in the past and continues to happen. And people extend it. It doesn't happen to me personally for me to believe that I do not trust this company. Very early in the vaccine rollout, I was looking up the different companies that make vaccines, and I came across this Pfizer trial, and I was like, oh, what's this about? And it turned out that in 1996, I think it was, in Nigeria, there was a Trophan Pfizer trial where it was a meningitis trial, and 11 children had died and many more been maimed as a consequence of it. And I was thinking, oh, so if I was in any way kind of knowledgeable about that, if I heard Pfizer and there was a kind of rollout, there would be a little bit of me that going, So it's that kind of stuff.
Yeah. Sarah, I'd love to pick up with you again on this, the experience of trying to get messages to multiple countries, localized communities. What do we do? What do we do better next time?
Well, I think, to be honest, I think we really need to rethink our communication strategies. I think they're based on a communication model that's archaic, top-down, linear, hierarchical, and I think is very much set up to fail consistently unless we do something about it. To be blunt, I think you only need to spend time with younger people to understand that the way that information is shared and created is participatory. People want to feel part of a movement. People want to be part of the co-development of that information. And our traditional authority setting communication models don't accommodate that. And I think, building on what you said, Mia, about, the way that you adapted everything to meet the sort of demands and needs of the pandemic, I think there's huge room for us to do that in the context of making sure that people have access to information that is not just accurate, but actionable. Like you said, there's no point in giving people accurate information unless they can translate it into their setting and translate it into what do I do now to protect my health and the health of people around me. And I think participation is really one of the key elements of that. Within this highly connected digital information ecosystem, as we call it, one of the most clear examples, and probably you know more about this than me, about participation, and I'll speak, from the context of public health guidance, because obviously that's what WHO does. In the Ebola outbreaks in West Africa, the management of deceased patients was a primary concern of transmission of the Ebola virus. So, of course, we developed the dead body management protocol, which, kind of ridiculous if you take it into a community setting where death and burial are such a part of culture, religion, faith. And so obviously through the engagement with community groups and religious leaders, it was then transformed into safe and dignified burial practices. So how do we do that safely, that acknowledges your culture, your religious practices, your beliefs, but upholds our hugely biomedical and sort of secular IPC things. So I think working out ways within the organizations that we work in, the networks that we have, the information flows that we need to support, ways that we can be more inclusive, more participatory in the way that information is generated and then adapted to different settings, I think is really key. And then I'm sure others will speak about this, but getting off our pedestals a little bit and realizing that sometimes the most impactful and trusted messenger is not the one we think they are, and finding a way very proactively to seek out, include, and partner with those people who are trusted messengers within communities and at a local level.
Yeah, absolutely. I'd love to open it up. Does anyone else want to follow on what Sarah has said about finding those local partners and messengers?
I would like to say that obviously for communication to be effective, you need to be inclusive and you need to be transparent. But it's easier said than done, because inclusivity is more expensive because it's more time consuming and you're involving more people and it's more complex. And it doesn't give you instant results. It's not that instant gratification, it has long-term results. Because you can use it for so many, if you build trust and you have that trust that's built, you can use it for so many other issues. So I think the way for the future, if we want to be pandemic ready, we need to be very consciously aware of the long-term consequences of partnerships so that we are prepared to invest more money in building them, even though we can't see instant results, because that's what's going to make us ready for a next crisis.
Mm-hmm. And on that point on investment in long-term partnerships, Eloise, what are your thoughts on how we sustain a lot of this cross-sectional collaboration in order to be able to do this and be always on?
In a sense, that's what we're trying to do at Pandemic Action Network. I think one of the things that struck us especially in the early days of the pandemic, was that appetite for a lot of not only civil society organizations, but a lot to engage. What should we be saying? What should we be putting out there? And a nervousness about saying the wrong thing. Rule number one of any campaign: do no harm. And so there's this: what's the protocol to turn the protocol into that translatable material, and how translatable can it be, and what degree of freedom can you allow campaign groups, etc. So I think we've got some thinking to do about how we use networks like ours and others, so that there's a core set of protocols and messages. And of course, we follow WHO, but I used the masking example earlier. It was tricky because WHO was a little bit behind the curve on that one, so we kind of went out there anyway, having spoken to lots and lots of experts. So I think there are those pieces. And then there's also a really important part, which we haven't talked about yet, which is fighting the misinformation and disinformation that is actively and proactively put out there. And I think a lot of us working in these on these issues, and we really want to do the right thing, and we're good at saying this is, we really want to persuade people to do the right thing, but we are, got our hands strapped behind our back if we're not fighting the bad things that are going on. And I think understanding and having a really sophisticated approach to tackle the misinformation and disinformation is really important. And I think also there are different levels to that. There's all sorts of nefarious kind of actors at play there, but some of it is just rumor, disinformation, and people's genuine concerns. And there are some learnings that can be generally applied from research, which you'll know much better than I, but there are things such as, in general, say vaccine mandates have a an off-putting effect, that if people feel forced, then it will actually create distrust, not encourage people to get on board. And then also the ways in which we talk about the problems and being honest about the risks and finding a way to talk about them, not suppressing that conversation, but finding a sort of safe space so that people don't feel they're being othered for having doubts. I think that's really, really important, and we saw some good work on that throughout the COVID-19 pandemic. But so some of this is very subtle, but I also think there's a lot of good energy and good people that want to help, want to put their networks, their communications tools pointed in the right direction. They just don't want to be half a degree out because they don't want to do harm. And so finding a way for the expertise to engage with groups like ours and make sure that we have the right information and the right kind of guidance on how far people can make it their own is going to be really, really important. And that's part of how we make it always on. And I would say that part of that is, this sense of the hesitancy aspect, the communications aspect. It's not a nice to have. It's essentially the whole fight, because talking about it, persuading people that what's important, how they need to behave, that is what we have during a pandemic, and especially before medical countermeasures are ready. And so I think there's also a kind of shift that needs to occur, that this is not a side issue, it's a fundamental part of how we tackle future pandemics.
Absolutely. I want to pause on the topic of misinformation so that we don't just move on. Would others like to come in on that? Your own experience, specific examples through COVID, ways we overcame it?
I think part of the problem is that science, the thing about science is, and the thing about the vaccines is that it's not 100%. So I think one of the things that is very difficult if you have had no exposure to scientific thinking is that you have the vaccine, but it's not going to prevent you from getting COVID. You might just get slightly less sick, but even that, if you're really if you're really unfortunate, then you might still get very sick, but most of you won't get. So it's kind of like this. So you go, and the thing with belief is that you can actually have absolute belief. So when you have science, which is this kind of, it's really good, it's really, really good, it's not perfect. And then you have not science, which is kind of, you just believe in it. And, there's nothing that you can, do. So it's kind of, partly it's just a kind of epistemological issue as well. And then layered upon that is the kind of social reality stuff of the past and the present and where people are situated in society, and also what else is going on. So it's not like, as professionals working in particular ivory towers, you sort of think that you've thought it through. There's an intellectual narrative running through the whole of your thinking, and so you get from point A to point M in a way that makes sense to you. But people are not inside your head, and lots of other stuff is going on. So they don't make decisions about their health in a vacuum where they're not also simultaneously immersed in their kind of their social life or their structural positioning in society, or what else is going on, and whether they've been denied a job, or whether they've been, profiled by the police, or whether they're facing immigration issues. They're dealing with a lot of things, and those decisions about health are being taken in the context of all of those issues. So, but the problem is that when people who want to do good, like by developing vaccines, by communicating about how effective vaccines are, by communicating how important it is to, to follow the public health campaign, they in themselves are doing good, and they believe that they are doing good, and, don't understand why people aren't following. But you need kind of intermediaries to actually connect those two, and the reality of people's lives may not be evident to somebody who just is in a lab developing a vaccine and is very excited about how effective it could be if everybody just took it.
One more question from me before we open up. And we had a really lively lunch. And one of the things I asked the panel was, how do you build trust? And the immediate response was like laughter. Well, you can't build trust. You just have to try not to fuck it up. You just have to make sure it doesn't go away. So my last question to the panel before we turn over to the audience is, what are some of the lessons of how we really messed up in COVID? What were the things that just destroyed trust that we can't do again? The juicy stories. Sarah? Sarah, WHO has been picked on a little bit.
I think it goes back again to the transparency and the assumption that everybody receives information from the same point and position with the same understanding. I think the greatest sort of damage to trust was really when there was a big disconnect between what people needed and what they were given or told to do. And I think, Tanvi, you mentioned this. Don't go to work, but there's, no social security and I'm employed in the informal sector. That's not a choice. So, when the government is telling you to do that, then the government is not responsive to your needs and doesn't care about you, then there's mistrust. And I think we saw that across many, many different sectors and many different situations. So that disconnect between the government not doing what they say they will do and what they're meant to do, which is very difficult, as we said. Everything was changing so dramatically, but not explaining that change adequately enough. This is the science that we have, and these are the decisions that we're making now based on that. Okay, we're going to change now because we've now learned this. It's okay, but doing it in a way that people understand it and so that it makes sense. And I think that science communication side was lacking and damaging, and then that disconnect between policy and actual people's needs, contexts, and cultures was the second more damaging thing.
I agree with you, but I think it goes beyond that. I don't think it's just how you communicate science. I think the messenger matters. And in many countries, like mine, where there was a lot of corruption during COVID, some of you may have heard of the digital vibe scandal in South Africa, where our health minister during COVID had to resign because he gave a friend a contract at a huge amount, the communications contract, and there was no communications money left for COVID because of this digital vibes contract. And if you then, an institution in which there isn't a lot of trust, and you try and tell people you can be as clear as you'd like to be, you're not going to be trusted. And I think in those situations, the solution lies in changing the messenger. So, something our health department did do well is at the beginning of COVID, when everyone was anxious and didn't understand why we had a lockdown, they took a scientist who communicates very well and put him on national television, and he had PowerPoints that everyone could understand, and because it didn't come from the politicians, people trusted it much more. And if you look in South African communities, say that our province, our most northern province, which is a really rural, poor province, had the highest vaccination rates initially because the communication was more appropriate. It's a very religious province. They used church leaders instead of sending nurses around. And there was much bigger buy-in. There were many poor communities where they used traditional leaders rather than, there was a very small poor community where the traditional chief took over the community radio station for a month, basically. And that community had an 80% vaccination rate, which was very high for South Africa. So I think who delivers that message is a really, really important thing. It's not just about the kind of message that you deliver.
Messenger matters. Eloise?
And ironically, the messenger mattered when it was a politician spreading negative information. So when President Macron said that the AstraZeneca vaccine is quasi ineffective, that just didn't have an impact on a lot of Europe. So I live in Belgium, and people were like, oh, my second vaccine was AstraZeneca, and people were like, oh, sorry. Then I talked to my British mother-in-law who went to Oxford. I got my Oxford vaccine. And so the cultural difference and that, the quasi ineffective comment, it wasn't just important in Europe, but it also rippled across Francophone Africa, the Francophone world. Mm-hmm. And so on the one hand, politicians aren't trusted, and yet, frankly, thinking about TBI, there's a good little training session for current leaders, I think, that could be set up to say, look, politics and Brexit aside, you've got to understand what you're dealing with, the power of your words and your actions, that you can't politic with that kind of thing. So those kind of incidences had huge ripple effects that we need to learn from. And I also think that we need to do the research in that crazy time of the sort of 3 year where it was rolling crisis all the time. We need to actually have that stop and pause, and that's why research into these communications pieces, what was said, what happened, who's analysing the social listening from that time, who's analysing how attitudes changed across time. It's really important that we invest in the research to learn those lessons as well.
Absolutely. Anything else? Or
only to just come back to Mia's point that all of that kind of getting the right messenger and getting to the point of people actually being receptive to what you have to say costs a lot more in terms of funding, in terms of time, in terms of human resources. They just need to be that investment needs to be privileged as much as the science and the actual thing that you're trying to deliver. And once that happens, and it's sustainable, the other thing to try and go forward with the always on approach would be to not suddenly jump into action when there's a pandemic, but actually build it so that we don't then, because the fall is a lot greater when there's a pandemic. So if these kind of trusted networks and intermediaries and communicators and messengers were already invested in as partners, as important to the response as everything else, then it wouldn't have to be kind of a sudden emergency where actually it turns out you're not communicating to a whole section of your population.
Absolutely. We have about 40 minutes left, so we still have quite a bit of time for conversation. There's hands going up. I'm going to set some initial guidance, which is 1, please tell us who you are very quickly. 2, make sure you're asking a question that ends in a question mark so our panelists can answer. And let us know if it's for someone specific or for the whole panel. So with that in mind, I have help from Jessie here to get the mic around. Let's start over here in the back. And if you're following us online, you can also submit questions and they'll come to my trusty iPad here.
Do you want me to stand up?
Yes, please.
Hi, Emma Ross from Chatham House. This is for anyone who kind of studied what had an impact on trust. And thinking about the UK, to what extent was there a real impact on trust of politician behaviour? So if we're talking about the castle, the Durham Castle thing, or sneaking out to go see your girlfriend, the policy makers who are setting policy and delivering policy messages, not keeping to that, was there a real damaging effect, or was it just convenient for political opponents to leap on it and amplify it? So what was the actual effect of that, if anybody has studied that?
Do you mean in terms of like quantified, or in terms of like just conversational?
I mean, was it anything more than, ooh, look, they can't keep to their own rules?
Yeah.
Did it have an impact in people saying, really, well, I'm not going to do it if they're not going to do it? The whole thing breaks down, or I'm going to go out for 2 hours, not 1 hour.
Yeah.
Or what was the actual effect? Does anybody know what effect that kind of behaviour had? Or was it just talked about?
Yeah, I mean, I think just from my research, those kinds of things were more amusing and a conversation piece. The things that really did have an impact were where inequalities were felt. So, for example, I had a few people who talked about how in the UK again, how the lockdown was opened for Christmas for a few days. I don't know if you remember, when was it, 2021, where it was like just 2 or 3 days where it was open because it was Christmas, but for Eid, it was not. And so it was this kind of like, hang on. And then there was a big surge, after Christmas, everybody, went and met Granny, and Granny wasn't very well afterwards. It was kind of, and so it was, so there was this, so those kinds of things seem to do a lot more damage than the occasional going out to see your girlfriend or driving to the castle. that was kind of more just a kind of, what's new? What a surprise. When you're talking about, the amount of money wasted on PPE that doesn't work, and that kind of the scale of those sorts of things, then the occasional kind of misdemeanors of individual people was less impactful in terms of eroding huge amounts of trust. It was already gone.
Next question. We've got quite a few hands here in the back.
Hi, I'm Paul Cadario from the University of Toronto, and I live in Washington, D.C., the, I think, global center of disinformation. Well, maybe not the center, use, generation, and receipt of bad information, dis and misinformation. In the general conference orientation to action, I would like to ask all the panelists to say, if you were given the request this afternoon that on Monday morning your organization or your network is going to do something, I mean something specific. I don't mean another study, I don't mean another, I mean something specific for Monday morning to move always on forward. What would that be? This has been a fabulous panel, but I'm waiting to hear what the action is. Thank you.
Okay, panelists, one action.
Lever that turns on the most lights on Monday morning.
Mia?
One of the partnerships that I don't think any journalist could have covered any pandemic is relationships with scientists. And I think during COVID, that was amplified, how important that was. And I don't think it's just organically going to coexist. And if we don't do something to formalize those partnerships, then we wouldn't be prepared for a next pandemic, because now everyone isn't a health reporter any longer. So what I would do on Monday morning is start to look for funding. We're a donor-funded organization, to formalize those partnerships, to have monthly get-togethers between scientists and journalists, to do things like, there's actually someone in the audience, Kurt, is a doctor over there, who did his 4th year medical elective with Bhekisisa. And that was a very mutual learning experience. We had a medical student who could teach us about medicine, and we could share writing skills. So I would apply for funding for fellowships like that, for having public health people do fellowships with us so that we can also learn from them. Yeah.
Amazing. Eloise, one action?
On Monday morning, I would also apply for funding in order to strengthen the network, particularly in sub-Saharan Africa, where want to really build this network of networks across climate, health, finance, gender organisations, so that we're not kind of going to people when the storm hits and saying, oh, hi, you happen to work on food and nutrition and you're very embedded in your community, or you work on FGM and you've been working with these women. But we actually say, look, we already know you. We're already providing you with a place to come to share your own asks and policy needs. But now is the time that we need to switch on for the communications and whatever public emergency takes place. So I think it's about building the networks to be always on that are also useful in between times. And I think we've got to build the equivalent of what we saw this morning, the brilliant presentations and speeches that we had. We've got to do that with communications in mind.
Tanvi.
On Monday morning, I already have funding.
Thank you, Oxford.
No, I mean, not really, but, and assuming that we don't spend the first 6 months applying for funding, but if I had the funding, on Monday morning, I would set up a series of public meetings, which would be a kind of a version of truth and reconciliation kind of meetings, where politicians, scientists, and media sit with members of the public who are chosen through some sort of citizen jury kind of process of representation, whereby we go through a post-mortem of what has happened during the pandemic, the mistakes that have happened, properly meeting on the same level with people who feel able to raise their concerns and have them responded to without feeling humiliated, without feeling disrespected, and also the people who have been in power and who have kind of introduced various measures to have the humility to admit, very openly and safely about mistakes being made. Because I think that unless you cannot move forward without actually having a proper investigation of the past. It's a theme I come back to a lot in a lot of my work, is that you can't do it. You have to actually see what the damage is before you can fix it.
Sarah.
I'm not sure I can follow that.
Oh, sorry.
No, I'm joking. I will do what WHO does best and convene. I would bring together a group of people from around the world to begin to discuss and define what trust looks like in the context of epidemics and pandemics, so that we can then advocate with our member states for it to be normalized as a key intervention within pandemic preparedness.
Thank you, Paul. That was a great question. Over here. Or you're right here.
Can we go here first?
Yeah, no problem.
Kate Smelina, British Columbia Centre for Disease Control, Canada. I'm actually wanting to move outside of health for a second and ask any member of the panel, is there an example you're aware of? If we cross science and pandemic policy delivery, put transport, finance, anything outside of health that's been done well? Or are the issues we're discussing right now, would you say, quite specific to health, and health perhaps is special?
Very interesting question, Kate.
I think in the context of the infodemic that we've heard talked about, that's obviously not specific to health only. What we're trying to do is understand, or to try and take a much more system approach to managing that infodemic, to make sure that people have access to information, and knowing that, and others on the panel have mentioned this, that as an individual, the way that you receive information from whom, how you process it, and then how you act upon it is so multifaceted and influenced by so many different things. So if you look at managing mis and disinformation and the infodemic more broadly, and take a systems approach, look at how does an individual interact with information at what point, whether that be health information for a specific health outcome or other, like you're referring to, it really then requires a very multi-sectoral kind of approach to how we design our information and communication strategies. So although I don't have a specific example beyond health, because obviously that's very much where I'm working, and I think it's very clear that approach to manage the infodemic is multi-system and multi-sectoral.
I think there's a lot to learn from South Africa's HIV program. We've got the largest HIV program in the world. And as many of you may recall, during the late 90s, early 2000s, our government was in denial about the cause of AIDS. And as a result, there was a lot of mistrust in treatment when it finally became available. It was regarded as poisonous, something that has too many side effects. So we needed a huge program in getting an uptake of the medicine. And what they did was community health workers and activists. We had a large group, the Treatment Action Campaign, who played a very significant role. And today there's trust in ARVs. No one thinks it's, not no one, but very few people would think it's poisonous. There's a very big uptake of it. Our challenges would be more adherence on a long term. But I think there's a lot of lessons from that program to be learned on how you can communicate well around it and use the right messages and increase uptake, yeah.
One more quick from Eloise. Just quickly, not strictly outside of health, but thinking about norm setting and behaviour change across time. If we think about the changes made on the tobacco fight that took, you know, if I think back to my youth, hiding behind my granny's sofa to avoid the smoke in the room, and then now no one will really smoke indoors. And of course, that's a series of regulatory pieces, but also civil society, campaign groups, activists. We have to remember, whether it's that or indeed on food issues and the sorts of things that are coming to light about different food groups. So you need a multiplicity of pieces across the board, regulation, information, but activism. And we have to have our constituency. And I think that's the really difficult piece about COVID-19. There's some brilliant groups like COVID-19 Families for Justice in the UK, a fantastic group who work really hard. But we also think about the people that suffer from mental health, the people that have long COVID, and survivors. So we have to really build those constituencies for change, because that was so important in the HIV/AIDS piece.
Thank you. Rachel Swift, variety of hats, but did policy advice for Australia, which was second for the bottom for COVID, but a veteran of many communicable diseases, so worked on the ground in Ebola in Sierra Leone, and before that polio. You said you asked the question over lunch, can you build trust? And I'm inclined to agree, you just have to not expletive it up. But all the data shows that trust in institutions has been eroding prior to COVID and continues to precipitously decline. And I would posit that a significant part of that is social media and hostile actors, particularly foreign actors, but any hostile actor. And we're now at the point where in Australia, which as you saw on the chart had an incredible journey through COVID, we've actually had police killed for attending a house from people who were radicalised with anti-vaccination messages. And I guess my question, because I've got to end with the question mark, is in that environment of active and intentional miscommunication and trust erosion, what can leaders, whether they're political, scientists, communicators, actually do to reclaim the territory of trust? Because whilst you may not be able to build it, if we can't do something to regain it, I think we're in quite significant trouble, and that's for all of the panellists.
That's a big one.
In 3 words, regulate social media.
Yeah. I think the first thing is that you have to use the same channels that the people who spread this information use. And I think research shows that one of the more effective ways to counter that information is to not address the person, but to address their audience. So what we did, if anti-vaxxers came for us all the time on social media, so if they would have an issue about side effects, say it would be a Pfizer issue, then we wouldn't address them, but we would use that as a cue as to when to do side effect stories. And when ivermectin was a big thing in South Africa, people got the ivermectin from vets. And so to sometimes not to be that direct. So we didn't do a story on why does ivermectin not work. We said, why is it bad to take animal medicine? Because then you do explain why ivermectin doesn't work, but there's less of a barrier for some people to get into the story. And we would then do the story at exactly the time when some famous person is using ivermectin, but we would never mention the person. Yeah.
Really interesting. Where's Jesse? Oh, on this side. Sorry, I'm turned the wrong way. Over here.
Hi, yeah, Francesca Dakin from Oxford, where I'm doing my PhD, which is also supervised by Tanvi. So hi, Tanvi. It's interesting to me the way that the panels talked about the need for transparency in order to build trust. And I think something that we saw during the pandemic was kind of an unveiling of just how much uncertainty there is in scientific development. And I'm wondering how, when you're at the boundary between science and policy or science and communication with the public, how do you manage being faithful to the inherent uncertainty of science, which is contested all the time by specialists? How do you manage communicating that faithfully whilst maintaining trust with the public?
I think it's about communicating that uncertainty. There's really no other way about it. I think saying what you know, saying what you don't know, the pitfalls around that and the implications of that knowledge gap and what you're trying to do to fulfill it. I think often people don't communicate about uncertainty because it's a sort of admission of some sort of inferiority or lack of competence. But as you say, the nature of science is such. And I think that's really a part of scientific literacy that can be worked on to be able to competently and humbly communicate about that uncertainty. And I think people respect that far more. They see through it anyway if you bluff over stuff and hide it. So,
everybody became a lay epidemiologist. Do you remember? Everybody was talking about R-naughts, right? I was like, wow, I remember learning that when I was doing my public health masters. But everybody, like, my aunt was talking about R-naught. Oh, the R-naught has gone up to this, and so maybe it is actually possible to give people a little bit of a science education and get as far as being able to communicate that science is uncertain and that it's shifting all the time. And maybe getting people on board is the kind of solution, is to kind of have more openness and less.
can I add something? I think there's also a clear partnership here between the scientists and the media and the scientists and the journals that are publishing that scientific work. Because I think what we saw during the pandemic as well was, really rapid publishing and preprints of articles being made available, and then that being picked up by the media and misinterpreted or interpreted sort of in a sensationalist way. So we're all for openness and transparency and getting information out there quickly, but there needs to be, I think, definitely some communication and partnership around how you interpret those results and the messages that you put out around those. So just wanted to add that as well.
Just another point, the importance of feedback loops and creating the space for uncertainty to exist, as in, and be questioned and discussed. So what you were talking about citizens groups and the space for people to be able to air their concerns, because it's not just about the broadcast mode of communication, it has to be two-way communication, which is why the networks in between times are important, because you need that extensive feedback loop to be able to rely on when you need it.
Here in the front row, can other people put their hands up if they have another question so I can see where you are now? Okay. Go ahead.
Hi, I'm Bhaskar Bhushan. I'm a cardiometabolic researcher at Airfinity. My background is very much not in infectious diseases, so I learned along with the sort of rest of the world as this was happening. But my question is, returning to the issue of the messenger is important. My understanding was that this was something that we kind of knew already. So from previous things like the Ebola outbreak, engaging local leaders is important and engaging religious leaders is important. From, as you said, the South African HIV antiretroviral rollout, don't have politicians, communicating incorrect scientific messaging to the public. How do we stop from rediscovering these effective ways of communicating the science for future pandemics and just sort of retain the lessons that we've already learned from the past?
How do we stop rediscovering the same things?
I think it goes back to what you were saying a little bit about the formalization. So I had exactly the same experience at the beginning of the pandemic when there were a number of outbreaks among religious communities. Oh, let's work with the religious community. So convened a group of faith-based organizations. They very directly said to me, WHO comes to us every time there's a crisis and then forgets about us the rest of the time. If you're going to do that, please just stay away. So the message came through loud and clear. And so I formalized the network, formal relations with WHO. We don't need to meet as often now as we were doing. It's once a month, it's ticking over, but there's been trust built over 3.5 years. And when there is another crisis where they need something, we need something, we have that space to go to and activate it, scale it up or whatever. So to me, it really is about that sustained mechanisms that don't need to be always on at full steam ahead, but always on ticking over, being nurtured in one way or another, ready to be scaled.
I think it's the difference between lessons learned and lessons acted upon. So whenever there's a pandemic or any crisis, there are great recommendations that come afterwards, and often they're left on a nice dusty shelf and may be ignored. But in all of these things, we don't win because we're right, because otherwise we'd be winning all the time. We win because we get organized. This is essentially about logistics. How do we build the networks, the interactions, the understanding of how we're going to get the right information at the right time to the right people? They all exist. We know a lot of what we need to do, so let's do it. And sometimes the conversations that we have kind of sort of, you're teetering on the brink of the policy conversation. We need to get to that implementation and action and empowerment phase. And that does require investment as well and resources. And those resources have kind of, the tide's gone out on a lot of them because COVID's no longer in the news headlines. So that brings me back to the conversation that we started with this morning. And, the idea that an action plan could actually reignite that interest at the most senior political levels is the most important thing we can do. Many people said, this is not, we do know the answers. It's about political leadership and political will. So it's brilliant that we're here, and thank you to the organisers for putting this on. We need to do this on prime time.
Can I maybe add one quick point to that? Because I think it was brought up in one of the opening and keynote speeches, which is about leveraging partnerships for multiple different needs. So yes, we did pandemics, but it's also climate crisis and refugee crisis, etc. So taking that approach, I think, is another way to sustain the work and the learnings.
I don't have the best answer, but I do think your question is a great one and goes even further, because it's about who we value. And that goes within a global context. It's the global north, global south relationships. Like you have mentioned, a pandemic is essentially a mirror that shows us what society looks like. And in South Africa, when the Omicron variant was detected, a lot of that mirror played out. The global north looks down on the globe, don't have the same values, basically. And I think in a global context, the global north is going to have to redefine what they consider valuable. And if there's a World Health Organization panel, you're going to have to redefine, do you want 5 Oxford scientists there? And what will they bring? And what will a Uganda scientist bring, or a community worker bring? And what is really necessary to get an inclusive approach that will have a long-term impact? But to change those things is a much bigger thing than just writing up the lessons of a pandemic. It's about changing views and how you view society.
Okay, I think we've got about 4 more questions. We have 12 or so minutes left, so I think we can get through the 4. Let's start here, because it's closest, and we'll try to keep responses quick.
Thanks. I'm Michelle Burbach, a consultant, and I just wanted to ask a question kind of related to this idea of consistency that was brought up in the beginning of the panel, and just wanted to ask about kind of what can be done when some trusted sources at different levels of the health system seem to be inconsistent. Some of the countries that I worked in during the course of the pandemic, a lot of the mistrust and a lot of the fatigue, kind of honestly, came from this idea that, well, my state department is saying something different from my local health department, from the CDC, from the national government. They seem to not agree with each other. If the experts don't even agree, then what am I supposed to do? You know, the province that I live in, I need to quarantine, I need to wear masks in public, but the next province over, they're not doing anything. Is the virus really that different across the borders, or like how could it be handled so differently? And I think we know because of decentralization, all of this implementation and funding, it's being decentralized down. So, you know, how can we think about trying to have some of these messages align better, or can they align better as a source of some of this mistrust that's happening?
How do we overcome inconsistency?
Well, one thing that we're doing...
I agree with you.
I don't think it's difficult, but I think you can take some steps. One thing that we're looking at, and our colleague from the Africa CDC mentioned it this morning, is trying to strengthen the relationship between the government and the national public health institutes, which are traditionally the kind of scientific base. So making sure that they are working much more closely together at a national level so that there isn't that huge chasm between the science and the policy. So that's one bit at one level. But.
Any other thoughts?
It's a mess.
It's a mess. It's a mess. That's the answer. Okay. Who's next?
Hang on.
So
Oh,
one
Eloise.
tiny point. I think it is a mess, but I think the inconsistency that we had during COVID is actually going to be something to prepare even more hard for if there is a next time. Because I don't think we're going to have the same run-in that we had, because there was so much confusion and we'd never had a situation like that before with so many countries in it. But we're going to have potentially a much bigger pushback on lockdown, social distancing, masking. The culture sort of split that came around in the first 6 months or so. You'll have people say, well, you know, in Europe, Sweden didn't do it, so why should we lock down? So I think that I don't necessarily have the answer, but the inconsistency, I think, will come home to roost a lot more next time. We sort of need to be prepared for that. And I think it's also an argument why governments and leaders need to get their act together, because they're not going to have the same bandwidth to be able to experiment, I think, as they had last time.
Mm-hmm. Mm-hmm. No, definitely agree with that. Hands. Oh my goodness. We're going to have to go really quick, Jesse. Can we take these two questions from the back at the same time?
Yeah. Okay. Hi, thank you all so much. This was great. So I'm Jessica. I'm from Northeastern University, and my question is touching a bit on what you talked about earlier, but I was a baby scientist at the beginning of the pandemic. And so when I got emails from media asking me to interpret like the modeling analysis that I was doing, I was just like, what is happening? And so I was wondering just generally if you all had any advice for scientists who are communicating and building partnerships with media. So I think so Mia, you mentioned de-jargoning in your earlier comment. And so I think I'm just selfishly looking for kind of nuggets of wisdom to become like a better science communicator.
That's great. Can we get this question? So we have one question.
Thank you. Hi, I'm Andrew from the Department of Health in the UK. My question is just about what you do when health outcomes conflict with trust, particularly when it's sort of long-term trust, as there may have been some instances in the pandemic where that might have been the case. And how do you influence the decision makers who might be prioritising sort of shorter-term outcomes when longer-term trust can be really important for the next pandemic?
Oh, that's a hard one. Mia, do you want to take the first question? Advice to the scientist.
Sure. So I hear a bit of fear that the media might get it wrong, right? If they ask you to do things that they may not understand, and maybe you use language that they want to break down, and maybe they break it down inaccurately. You do have the right to ask for your quotes, to see that before it gets published. It's not a general accepting, you wouldn't generally get the entire story, but you can ask for the bits that your quote is in, and that there's paraphrasing before your quote. During COVID, we broke the rules. We're not supposed to ethically give the entire story to a scientist, but because we were so scared of getting it wrong, we just broke it. It was a pandemic. We just gave the whole story. And, you know, that no one really, interestingly, none of the scientists were controlling and started to rewrite the story or change other people's quotes and stuff. So that's the one thing. The other thing is, you know, I think there's a lot more sense in investing energy in a few journalists who you trust than trying to reach the entire network of journalists, because I think that's more powerful. If you have a story idea, for instance, a general journalist that you don't know, it's probably not going to fall for it. But if you have a personal relationship, that would work better. We get a lot of our story ideas, at least half of them, from people in our network who would call. And we published a story yesterday of a doctor who wasn't even quoted in the story about cholera in South Africa. It wasn't our idea at all. So I think that's something to look at. And an interesting thing that happened with us during COVID was because scientists essentially became celebrities, right? During COVID, you were on TV all the time, and became quite aware of the need for skills. So some in South Africa came to Bhekisisa and asked for online courses for media skills. And they wanted to learn how to write op-eds because they wanted to make their voices heard. So we now have an income generation where we present op-ed courses for policymakers and scientists, and the interest is immense. They pay for those courses. I didn't know you guys want to write so badly, and and they're not writing badly after that. So
there you go. So everyone can sign up for Mia's course. Anyone want to take the question on the balance between the short-term outcomes and the long-term win and trust?
Peer pressure, maybe, is one of the most effective strategies to get politicians to think short-term. And I think it was mentioned earlier as well in one of the opening panels, a little bit of transparency around what he's doing and the praise that he's getting for that. And I think it's one way to shift the needle a little bit to get politicians to think a bit more.
Public pressure, media focus, activism.
Yeah.
Mm-hmm. Yeah, strengthening civil society and the effectiveness of being able to analyse what's going on.
Great. I'm going to break the rules. I have two questions here in the front. They're the last questions, and they need to be short.
Hello, Karina Grimes here. I work for NHS England, but I'm here as an Atlantic Fellow. So the Atlantic Fellow has 7 programmes globally. It's a diverse group of people, and I think based on this gentleman's question about Monday morning, so there is opportunity for collaboration. There are fellows in South Africa. There is funding available within the Atlantic Institute. It is very much from an activist point of view, and the whole drive and theme of the 7 programmes is all about addressing inequity. So I think that there could be great collaboration between the Atlantic Fellows and delivering on this action plan, and the whole idea of trust. And you talked about, so that whole idea of restorative justice has been a key theme, particularly one of our last convenings where we looked at conflict from colonised populations. So I think it would be really a great opportunity for us to develop our mission and help deliver some of those actions for Monday morning then as well.
Wow. Okay, so we have a pitch for partnership with the Atlantic Fellow. We are now at time, and I apologize, but the good news is we have a 30-minute break to continue conversations upstairs. So right now I want to say a huge thank you to the panel. If we can give them a round of applause, please.